Hello everyone. Today we are going to talk about an important topic, that is brain death and how to assess that. And as a physician or as a practitioner, we need to be aware of how to assess any patient of a brain death and how to declare a brain death patient. So coming to the definition of brain death is defined as a permanent, that means there should be a permanent and irreversible cessation of all functions of the brain. That means that all the functions of the brain has to be completely stopped and there should be irreversible. So there should not be any reversible cause which can reverse it back. So it has to be irreversible and permanent, which resulting in coma, absence of all the brainstem reflexes, and there should be apnea. That is absence of spontaneous respiration despite adequate hypercarbia or acidotic stimulus. So all these three features has to be there to label any patient as brain death. So how do we assess or ascertain that any patient is having brain death? There are four things or step procedures to be followed. First, minimum prerequisites which has to be checked, neurological examination, apnea testing, and few ancillary tests whenever required. So what is a prerequisite before brain death testing is that before conducting any brain death test, all confounding and reversible conditions. So suppose a patient is unresponsive, all the reversible causes has to be seen and look after. And once that all the reversible causes has been ruled out or all the confounding factors has been ruled out, then only you should try to analyze the patient whether the patient is brain dead or not. So first is established any etiology of brain injury. This is the most important part. Cause for a brain injury has to be established. There should be a clear evidence of catastrophic irreversible brain injury, and common causes are any traumatic brain injury, hypoxic ischemic encephalopathy, intracranial hemorrhage, massive ischemic stroke, and herniation of the brain. So neuroimaging, if done, should be consistent with these clinical findings to establish the etiology of brain injury. And point to be noted is that brain that cannot be diagnosed if the cause of coma is unknown. Next, excluding the confounders, all the confounders has to be excluded because suppose there is patient is in hypothermia, this patient can also behave as if he is brain dead, but if the temperature is improved, the patient can get conscious or show some signs of brainstem reflexes or brain activity. So this has to be ruled out. The patient core temperature should be more than 36 degrees Celsius. BP should be systolic pressure should be more than 100 with a map of more than 75. There should be no CNS depressant drugs, or it has should at least has passed more than 5 half-lives. Alcohol blood level, if it is there, it should be less than 80 milligrams per deciliter. All electrolytes like sodium, potassium, and thyroid, everything has to be corrected, or any acidosis, everything has to be corrected. And any neuromuscular blockade. So when patient suddenly collapse, we give neuromuscular blockade sometimes to intubate the patient. So all this neuromuscular blockade effort has to be excluded by doing either a drain of four or reflexes to be checked. Next important thing is to do is clinical neurological examination to assess for absence of both cerebral as well as brainstem function. So both cerebrum and brainstem function should be stopped. Then only a patient is labeled as brain dead. So first assessment of coma, how do we assess is that it is to confirm that there is complete unresponsiveness. How do we do that? We apply a verbal or visual or noxious stimuli. Noxious stimuli is done is like supraorbital pressure. As you can see here, we are applying pressure above the eye in the supraorbital region. Deep and tight or severe pressure has to be applied. If patient is not responding, because this is considered as a very severe form of pain, a normal person cannot tolerate the pain if you press here. So it is called as the noxious stimulus, which is applied supraorbital. Other thing is the nail bed, which we can apply pressure here. And again, one is the trapezius squeeze. So the trapezius muscle you can see near below the neck, and if squeezing of the trapezius muscle has to be checked. And if there is no response, you assess that the patient is in coma. So what is the required funding? There should be no eye opening, there no motor response, and no vocalization. If any of this response is there, patient cannot be labeled as brain death. Next, coming to assessment of motor response to confirm absence of cerebral mediated movement. So apply endonoxious or severe stimuli to either face, trunk, and all four limbs has to be applied, and absent movement is required. So if the patient is in coma, there will be no movement. There are few spinal reflexes which a patient can have, which is because of the spinal cord functioning, not because of the brain functioning. So suppose the patient is brain dead with both cerebral and brainstem not functioning, then also few reflexes can be present because of the spinal cord. This is called as spinal reflexes. And presence of spinal reflexes does not mean that the patient is alive. So brain patient can be brain dead with the presence of spinal cord reflexes, which are three things, which is Lazarus sign. Lazarus sign, where you can see that the patient can suddenly flex his arm, and you can see in this position. So arm raises from the bed, elbow flex, hands may cross over the chest as you can see here, and it's sometimes accompanied by the neck or trunk movement. It is basically triggered by the hypoxia and removal of ventilator support or flexion of the neck, and it is mediated by C5 to C7, that is cervical spinal cord. So what is its significance? It is dramatic but not non-purposeful. It is completely spinal in origin and does not represent that patient is conscious or brainstem function is intact. And presence of this does not mean can still mean that patient is brain dead, because it is a spinal cord reflex, not a brain reflex. Second is triple flexion response, which is also another spinal response, which is seen basically because of L4 to S2, that is lumbosacral spine, where a patient will have the triple flexion of the hip, flexion of the knee, and dorsiflexion also. So all these three can be seen normally reflex in this case. So it is a pure spinal reflex. It can also be present in a brain dead patient. And finger jerks is the last thing. Some patients have a brief involuntary twitching or flexion movements of the fingers, which is seen in comatose or brain dead patients. They are spinally mediated reflexes, and it can be elicited by noxious stimuli such as nail bed pressure. So next important text which we have to do to assess the patient is to check the brainstem functioning is, so basically brainstem involves the pons medulla and the cranial nerves which is present there. So testing of the cranial nerves will help in indirectly assessment of the brainstem reflexes. So midbrain function is assessed, that is cranial nerve 2 and 3 by pupillary light reflex, where we put a light or a torch on the one eye, and usually there should be pupillary constriction. And if there is no response, that means there is fixed dilated or mid position pupils, or no response to light bilaterally, it means that patient is brainstem dead or brain dead indirectly. Next thing is corneal reflex, where we take a piece of a cotton which is folded like this, and it is touched directly to the cornea, and this should usually lead to blinking, bilateral blinking. There is blinking of the both eyelids. Eyelid should be there, and if the patient is brainstem dead, basically it tests the pons function, a cranial of 5 and 7, and if there is brain death, will be no blinking or eye movement. Next is called as oculocephalic reflex or doll's eye phenomena. Here, what happens is you should first check this patient cervical spine is integrated or not. If there is any spinal cord or there is cervical spine injury or cervical spine trauma is there, this test should not be done. So to assess the brainstem integrity, you have to rapidly rotate the head side to side or vertically. So you do a head right side to side movement or vertical movement. And generally, when the head is moved as this side, as you can see here, if the head is moved in this side, usually the eyelid or this cornea or eye movement will be there on the opposite direction. You can try on yourself or on some of your colleagues. You can see that if the head is moved suddenly to the left side, the eyelid will move to the opposite direction, which is a normal phenomenon. In brainstem dead patient, this will not be there, as you can see in this patient, because since the head is moved here, the eyelid is also going towards that direction only, the same direction. It is called as positive doll's eye phenomenon. So you can see here, if the head was rotated to the left, eyelid is also going on to the left side. So brain death finding is eyes move with the head. There is no counter movement. Normally, there should be counter movement of the eyes. Next, coming to cold caloric reflex, or also called as oculovestibular reflex. It tests the both pons and midbrain function, where we put ice cold water in the ear and observe for eye movement for 1 minute. So you have to elevate the head for about 30 degree. irrigate ear with ice cold water. So normally wherever the ice is put, automatically the eyelids will move towards that direction. As you can see in this patient, see eyelids are both and towards the direction of the ear where ice water is poured. Suppose patient is brain dead, there will be no response. As you can see in this patient, after pouring the cold water also, the eyelids remain in the center position. There is no movement in that. This means that patient is brain dead. It is used when oculocephalic reflex or doll's eye cannot be tested. Next test is the gag reflex. It tests the medullary function, that is cranial nerve 9 and 10. You have to stimulate the posterior pharynx either with a cotton, or you can take a forceps to stimulate the posterior pharynx. Normally, there should be a reflex with that. Uh, no palatal movement or gag response. It means that patient is brain dead. Next one is cough reflex. Again, it assesses the medulla. You patient is this patients where we are doing a brain dead assessment usually will be on ventilator support, and there will be endotracheal tube for them patients. So you can do suctioning of that, do deep tracheal suctioning, and usually if the brainstem is intact, patient should usually cough. If there is no cough present, that means that patient is brain dead. And last and most important test is the apnea test, where we try to induce hypercarbia in this patient. So what we have to do here is that, so normally whenever there is increased CO2 or acidosis in the body in any patient, it will increase it stimulates the respiratory system and the respiratory rate increases. So to induce that only in that brain dead patient, what we do is we do pre-oxygenate the patient with 100% oxygen. So you have to, for 10 minutes, you give 100% oxygen to the patient. Then you do is disconnect the ventilator and you just provide the normal oxygenation. Just 2 liters or 4 liters of normal oxygenation is given to prevent the hypoxia. And observe for chest and abdomen and obtain ABG. Take ABG after 8 to 10 minutes. If the patient is normal, there will be some respiratory effort. Also, there will not be any acidosis. pH will be more than 7.3, and PaCO2 also. Patient will suddenly wash out the CO2 also, and PaCO2 will be less than 60. In patient of positive apnea test, that means suppose the patient is not at all breathing, what will happen is that after giving oxygen, all this carbon dioxide will form, but it is not going out. So PaCO2 will increase more than 60, or it may increase to more than 20 millimeters above baseline. And there will be no respiratory effort, and patient will go into acidosis. So all these three things confirms that patient is having positive apnea test. That means the patient is brain dead. This test has to be aborted if there is hypotension, saturation is less than 85%, and or any arrhythmias is there. What is the prerequisite? Patient should be normothermia, normotension, euvolemia, PaCO2 should be 35 to 45 normally maintained. On some patients, suppose patient is already a case of COPD, may have a little slightly higher than these values. So baseline for that chronic retainers. So whatever is baseline for him, that has to be maintained. Or if your baseline is not known, you can, for him age, you can keep some PaCO2 value and just check that baseline PaCO2, and then after 10 minutes ABG, if it is more than 20 increases there, that means patient is having positive apnea test. And after pre-oxygenation, PaO2 should be more than 200. Next test is the ancillary or confirmatory test, just to confirm the clinical findings and to give the final evidence. You can either do a cerebral angiography, which will show no intracranial blood flow. You can do a radionuclide perfusion scan, which will show a hollow skull sign. Transcranial Doppler will show absent or reverberating flow, and EEG will show complete silence with no brain activity. So this ancillary tests just support but do not replace the clinical diagnosis. Indication: incomplete clinical examination, unsafe apnea testing, and persistent confounders if present, then you have to go with this ancillary testing. If you like our channel, do subscribe to our YouTube channel, infusionmedz.com or Infusion Medical and Education Zone. And we also provide other services with concise notes, research assistance, and publication assistance as well. Thank you.